Thank you and good morning. Thank you, Dr. Mansour. First of all, I would like to express my extensive, thanks for, the Saudi Society for Rheumatology for inviting me, and it's a great honor and privilege to be with you here. Rheumatology in general is not far away from rheumatology, and put it in a mind that uveitis or intraocular inflammation is just a small part of ophthalmology, and not all the ophthalmologists were specialized in the intraocular inflammations. Most of the ophthalmologists, they having difficulty and challenging to specialize in this because it needs to have a lot of knowledge deep in the autoimmune disease, systemic autoimmune disease, and to be aware and have deep background about the immunosuppressive, immunomodulators, medication, new medications and trials in the field. So starting to talk about my part, what rheumatologist needs to know, I would like to express that I don't have any financial or conflict of interest with this talk. So when we are looking for, our way how to deal with the uveitis patient, usually you have to have good workup with appropriate lab works. Then we have to have enough of the right medications and used to long enough to treat our patients, and to have to know well the time to move to the other treatment or management, and knowing when to refer and not operating unless absolutely necessary in this patient. Why we are saying that? Because, dealing with the uveitic patient, it needs to have quiet eye. Otherwise, might be the patient will lose his eye. Then, how to choose your treatment? Usually to have the diagnosis, really, is it anterior, intermediate, or posterior? Then you have to assess the severity of the intraocular inflammations, and then the durations. Either you are dealing with acute or chronic type of intraocular inflammations. And then to look for how. Is it reversible disease? Is already the damage already been there and cannot be reversed? Then is it unilateral or bilateral disease? Because this is an important. When you are dealing with unilateral, might use only topical or local medication. While bilateral, then you have to might use more than that. Then the presence of concurrent systemic disease. And this is an important when you are starting your patient either in systemic steroids or immunomodulator medications, to assess this carefully and to refer your patient to internist or rheumatologist or even though the oncologist. How to look for that? We have to assess how this drug could affect our patient and looking for side effects, and then if the general health of the patient is acceptable to start or not. And this is including diabetes, hypertension, renal failure or renal disease or liver disease. And then the compliance of the patient. When you are dealing with the pediatric groups, usually it's not the same as the adults. So here you have to put in your mind, not just to give the patients and the mother or the parents the drops and tell them that to use it. Might be need another aggressive mode of treatment, either to have local treatment by injections under general anesthesia or to have systemic treatment. Then what are the aims when you are treating patients? It's an important thing to suppress the immune system sufficiently to improve the vision and to prevent additional damage to the eye, in the same time to make the patient comfortable, not to be that having long time, disease problems, and you have to have quick as possible to relieve the intraocular inflammation. And then to minimize the side effect by using the least amount of medicine. It is simply that our treatment, it is either topical, local, or systemic therapy. This is just only small, words, but for us it's meaning a lot. So when we're starting to use topical therapy, it could be steroidal, non-steroidal, or could be sometimes use some sort of, immunosuppressive medication that designed for intraocular use. Then we have local therapy, either used as subtenon or could be used intravitreal either systemic steroids in implants, short-acting or long-acting, then systemic therapy, and you are the master of that, and usually you are in treatment. When you are looking for taking patients, it is not different from, internal medicine, and uveitis specialists, usually they have to be aware. We're starting with history, and using history alone, it might be helping you to diagnose 56% of our intraocular inflammation etiology. Then added by, physical examination, either just only ocular or even though the systemic examination that increase the probability of diagnosis to reach 73%. We are not really depending on just the investigation. Lab investigations might not be adding, a lot for diagnosis and accurate diagnosis of intraocular inflammation. So usually we put it based and tailored in our physical history and physical examinations. So we need multiple evaluation to reach the diagnosis. Maybe early primary diagnosis is not the final, and usually the intraocular inflammation might be having some masquerading or mimicking each other. So initial diagnosis or primitive diagnosis might be not the final diagnosis. So we have multiple evaluations which are necessary to disclose the local, ocular or systemic disease responsible for the patient uveitis. And put in your mind that the uveitis specialist usually is a small or the small parts of internal medicines. We have to reach our patients, so our approach depending actually in the research and how it is. So looking for the guidelines in non-steroidal systemic immunomodulatory therapy in uveitis, we have an experts, evaluations, and usually we sit together and having round tables, and we have one of the great paper that just published on ophthalmology in 2018, and this paper having focus area to look for. The first focus area was optimal timing for treatment, then the focus area to that transitions treatment to non-corticosteroid systemic immunomodulatory therapy, including biologics, and the third focus area is collaboration across the multidisciplinary. And in conclusion of the study, that consensus guidelines were developed based on the published literatures, expert opinion, and practical experience to bridge the gaps between the clinical needs and medical evidence support treatment of patients with non-infectious uveitis. Then we have another paper to compare between our treatment, including, for example, Silsipt and methotrexate, and we found that that methotrexate is not inferior to the uveitis treatment when you compare it with the Silsipt or other medications. And to look for the pattern, because uveitis is not the same as in the geographical distribution. The causes of uveitis in the Middle East or in Saudi Arabia differ from that in India or China or even that North Europe. So we have papers and showed that most of the causes of uveitis non-infectious in almost 80% of our patients. Looking for the causes of that, we have found that Vogt-Koyanagi-Harada syndrome was the most important cause of non-infectious intraocular inflammations, followed by Bahjat disease and then idiopathic anterior uveitis. And when you are looking for juvenile idiopathic arthritis associated uveitis, almost 1.6%, followed by HLB. I'm going to show you some cases that we see in reality, and that might be not seen when you have a patient with certain disease. This is one of an ocular disease called FKH. When you look for that patient, usually they have some sort of retinal detachment called serous retinal detachment, and this is an accumulation of fluid under that retina. The patient, usually young females, coming in their 20 or 25 years of age with blurry vision. If this is neglected, could be lead to decreased visual acuity with recurrent attacks, might lead to permanent ocular damage. We are using fluorescein angiography, could show all the pictures, and we have one more weapons that could be used or means to diagnose this patient, which you call optical coherent tomography, and that looks like CT scan or MRI of the eye and can show all the layers of the retina and see the subretinal fluid that at the area of the cause of the decreased visual acuity. Could be used for diagnosis and at the same time to monitoring the effect of our treatment to these patients. This is another patient using the wide field and looking for the subretinal fluid that easily could be seen by ophthalmologist. Looking for the OCT gain, it can see easily the retinal detachment and the subretinal, fibrin deposit and signs of inflammations. Fluorescent angiography easily can show, and so this is the brief about it, how you can stage the disease and looking how it is. It is usually in acute stage. It's bilateral and grammatus uveitis, and could be then moved to convalescent stage where there is sunset glue fundus, almost changing whole because of loss of tyrosine and retinal pigment epithelium. And then we have the systemic manifestation like vitiligo, alopecia, and even though some sort of loss of hair. This is easily diagnosed clinically and aided by OCT and even though the fluorescent angiography. And the treatment needs systemic treatment, steroids plus immunosuppressive medication, and in the resistant cases, we can use almost the biologics. Another disease that it's important for us is a Bahjat disease. This is one of the patients that I have it, having really young patient, almost 12 years old, that rotating between doctors without diagnosis, and after 2 years that he lost his left eye and coming with no light perception in that eye, and his only eye having this picture, which show that occlusive retinal detachment, pale disc, and vasculitis at the time. The patient is having real signs of Bahjat disease, that having mouth ulceration, genital ulceration. The patient was handicapped and moved in the emergency room in his wheelchair with his mother. And upon assessment of that patient, the MRI showed that cerebral venous thrombosis. So this patient's life was at level of really severity. Referring this patient with the usual, routine way, it might be delay the patient, treatment, and might be the patient lost his life. So the patient sent to one of my colleagues, might be he's not with us, is Dr. Jubran Ganatish, who's really take the patient immediately to the ICU and treating the patient aggressively with the anticoagulations and immunosuppressive medication to biologic. It is too late for this patient, but at least we can preserve his eye to reach just only, vision that mandatory for him to at least to read. And this is his fluorescent angiography. You should look for that retina is very thin because of recurrent attacks of, retinitis and vasculitis. If I'm just, the time is to, get more than what I need, please, just enjoy. This is another patient. It is important for all the rheumatologists to be aware about it. See clearly the inflammation that we are assessing. It might not have this chance to have it when you are assessing your patient. But in our patient, easily we can calculate the cells in the anterior chamber, and you can categorize that from, low severity to increased severity to 4+. So that's important for us how the patient is responding to our treatment. This patient is a case that presented with sudden loss of visions, and when you look for him, he's having, neuroretinitis, having vasculitis, and even though occlusive vasculitis. This is wide field for the same patient, and you can see clearly you see the signs of vasculitis, of coughing, and leaking from the blood vessels. We added this is with OCT, fluorescent angiography, and clearly we can see staining and leakage from the retinal blood vessels. And after treatment with immunosuppressive medication, including intravenous methylprednisolone and Solcept, and even though adding for him infliximab, the patient recover, and even though that we can able to preserve his vision. This is just only briefly how it anchor. Another patient is important, is ankylosing spondylitis. This patient presented with acute blurry of visions with red eye, and they presented with usually fibrin and hypobia like in the anterior chamber. It's important to be seen by ophthalmologists and treatment easily, usually with systemic immunosuppressive medication, and we can easily this patient treated. This patient is important to be referred immediately to rheumatologist to assess him for systemic disease associations by doing MRI of sacroiliac, and might be the patient need to be put in aggressive treatment with biologic and immunosuppressive medications. Usually this patient is having uveitis almost in 40% of the patient. I will conclude this is another disease. It's called scleritis, and 50% of this patient associated with the systemic connective tissue disorders and autoimmune, and it is lethal disease, could be lead to loss of vision. This is another patient with aggressive necrotizing scleritis. If you see in these pictures, superior and inferior, and this is assisted by CT scan of this patient. It is one of the life-threatening cause called grammatosis with angiitis, which is Wagner's, and this is need to be treated immediately with very aggressive immunosuppressive medication and immunotherapy, including cyclophosphamide. This is the differential diagnosis of scleritis. Another disease that is important for the pediatric rheumatologist is juvenile idiopathic arthritis. This is patient having an anterior non-grammatic uveitis that might be not discovered early and lead to late complication and loss of eye with phthisis palpi. So this is just only how we can screen our patients, and this is the characteristic of this small children presented with juvenile idiopathic arthritis related uveitis. And the most important, 20% of them, they having oligoarticular. And the most important as well, how to follow this patient. Each one of them is having risk factor, and we have to look for them carefully and how to send them for screening with the offer. Usually the risk factor includes young age, less than 7, and female gender are at risk more, and oligoarticular onset is really risk factor, and ANA positive patients. So what are the things, bottom lines, that you need to know from our side? Usually ophthalmologists are not comfortable with immunosuppressive medication, except a few of them. And if you know the eye as rheumatologist, you will be better rheumatologist, because most of rheumatic disease involve the eye. Ophthalmologists need you because they are not really prepared to deal with systemic disease and systemic medication, and rheumatologists should be make greater efforts to collaborate with ophthalmologists. This is the statements of our mentors, and this is the areas where you have to refer your patient when the patient having red eye, when the patient decreased having vision, or dry eyes. So in conclusion, we have 7 things ophthalmologists want rheumatologists to know. That include that don't ignore ocular symptoms, and when you get referral from ophthalmologists, encourage them to be specific as possible, and be careful with the steroids, because this might lead to cataract and glaucoma in patients, and enlist on ophthalmologist help for the treatment of dry eye disease. Don't back off the therapy too quickly, because this might be affecting the intraocular inflammations. Hold simultaneous clinics with your ophthalmic colleagues when possible, and expect certain treatments to be part of ophthalmologist armamentarium in the future. We are depending on you, and what you are using, you are the experts, and might helping us to preserve our patient vision. I would like to thank you all for giving me this opportunity to be with you and to talk, and wishing you fruitful meetings. Thank you, and thank you a lot.